I'm Dr. Finney. I'm a pediatric emergency medicine and EMS physician at St. Louis Children's Hospital. I'm the director of EMS for the Children's Hospital, so I know I'll see you guys from time to time coming into the emergency department. So it's really a pleasure of mine to be able to talk about this here today. I start this talk off, and I actually start off my pediatric trauma talk with the same slide, and this is actually a picture of my daughter who's now, this was a couple years ago, I want to say it's probably 2 or 3 years ago. What you'll notice about this picture is that she actually has a black eye on her right eye, and this of course, as irony may have it, I was actually putting together my pediatric trauma talk when she fell off the toilet and gave herself a black eye. So 1, 0 points as a father, and 2, 0 points for work-life balance. But the whole reason that I keep this picture up here, besides the fact that she loves it, is that it shows the unique anatomy of a pediatric patient and why children have unique injuries compared to adults. So why is it that children get black eyes with some frequency, but adults don't? Now, when you get really old, and I would say children and the elderly have a lot in common, but when you get really old, that starts to happen again. And there are unique physiologic factors and anatomical factors that make this injury much more likely in my daughter than it would be in anybody who's watching this. And we'll come to those in just a minute. The objectives of this talk is to provide an overview of pediatric traumatic brain injury, discuss key areas of patient care, review evidence-based literature on the emergent management of pediatric traumatic brain injury, because the care that's provided in the acute setting is critical. It is the most important care, I would argue, and I would say that traumatic brain injury ranks highly above the things that paramedics, pre-hospital providers have an opportunity to intervene upon. So really, really important that that early care is done appropriately and quickly. I envy cardiologists because as the heart gets sicker, more and more information becomes available to guide management. EKGs, vital signs, chest x-rays, echoes, troponins, BNP, and even patient-reported symptoms. As the brain becomes sicker, less and less information is available. The physical exam goes away, patient complaints go away, imaging may not show moment-to-moment changes in pathology, and intubation and paralysis, are often necessary, further limiting our ability to get a good exam. The earlier and more complete the neurologic exam, the better I can anticipate the expected or necessary treatment. So really, really important to think about that for a second. As a traumatic brain injury matures and develops over time, that patient becomes less and less interactive with the provider, can provide less and less information about how they feel, patient symptoms, things like that. And so we are left sort of guessing based on mechanism, based on exam findings, based on vital signs, what might be going on. And I think that really is the crux of what makes the management of traumatic brain injury so difficult. Because in a lot of ways, if you aren't looking for it, you aren't going to find it. I'm going to talk about a few things that are also very important to me. One of them is the changing landscape of pediatric traumatic death, or pediatric death in general. The landscape of pediatric injury and death has changed over time. So 1999 on the XY intersection there, and then 2020 on the far end over here, which is now, unfortunately, 4 years outdated. But this is a really good example. This was published in JAMA in 2022 to show that the landscape is changing. So motor vehicle crashes, we did a really, really good job of decreasing the risk of death or the chance of death from a motor vehicle crash. And then now in the last couple of years, we've actually had an uptick in that. What's striking here is this gold line, firearm-related injuries have gone up significantly. And this is firearm-related death, so really, really important. Additionally, what has gone up significantly is drug overdoses and poisonings. More so than malignancy, neoplasms have stayed roughly the same. Our SIDS deaths or suffocations have stayed roughly the same. Congenital anomalies, heart disease, drownings, fires, burns, chronic respiratory disease, those have all stayed relatively the same, but we're seeing a rapid rise in motor vehicle accidents, firearm-related injuries, and drug overdoses and poisonings. And so it's really important for you as a pre-hospital professional, an EMS professional, to consider this graph when you go to the next pediatric patient that you're taking care of with critical illness. Think about these other causes, so especially drug overdose and poisoning. Motor vehicle accident, I hope you can tease out that that might have been what caused their injury, and firearm-related injuries are going to be something that we're unfortunately going to see more and more commonly. So really important to put this in the back of your mind. And I would argue that 2020 to 2024, things have not gotten better. I would say they've probably gotten worse. And it's not just me saying that. You can see gun deaths fell in 2023, except among kids. So this problem is getting worse and worse for our pediatric population. It is obviously a public health crisis, along with other things, which I'll show you here in a second, but something that we have to keep in mind. And management of pediatric penetrating trauma is such a critical aspect of our pre-hospital care, and everybody should be familiar with that as best as they can, and also with prevention and public awareness as well. All right, so the other big thing, if you go back here, I'll show you, go back to this slide, you can see drug overdose and poisonings was the next big one rising on the list. So getting to that, you can see pediatric opioid exposure is rapidly increasing. And this is, again, taken from JAMA, but this is only comparing the National Drug Exposure Database or Toxic Exposure Database, National Poison Data, that's what I'm trying to say, to Oregon, and it's only for children 6 years of age and younger who didn't die. So a huge percentage of patients who actually die from this, and I have a whole talk on pediatric opioid exposure and death that I will gladly come back and make you guys listen to. But this is for children who don't die, and you can see the exposure rate took almost a straight up turn here back in 2020. So a rapid increase in pediatric opioid exposure. So when you see your next pediatric patient who is altered, undifferentiated altered mental status, traumatic brain injury, which we're going to talk about at length today, and opioid exposure should be top 1 and 2 on your list. The other things you can deal with lower down, but those two have to be 1 and 2 that you're thinking about, because those are going to be the common causes of death in the pediatric population. And you'll say, well, that's only an adolescent or young adult problem. And I would argue that no, it clearly is not. This is pediatric opioid overdoses in an emergency department, and you can see a bimodal age distribution. Younger patients in the toddler range, 3 to 5, and then older patients are the ones most likely to be exposed. So it absolutely is a problem you're going to see in our younger toddler range patients, just like traumatic brain injury is going to be. All right, so I want you guys to consider a case for me. So it was my first or second day as an EMS fellow. We were riding out in North County. I was with one of the EMS physicians who had been doing this for a really long time. We are, driving down one of the main roads, and we get a call that comes out for a pediatric patient hit by a car. So of course, I'm a pediatric emergency medicine physician doing an EMS fellowship. This is a great opportunity for me, right? I should be the expert on scene for this patient. Get on scene, the child is clearly altered. He's not unresponsive, but he is very somnolent. We get him on a backboard, place him on a cervical collar, put him in the back of the ambulance. I, of course, as the pediatric expert, ride down to the hospital with the paramedics. And during transport, patient has 3 or 4 episodes of desaturations into the 80s, to the point where we would stimulate him, he would come back up, and then he would drop back down a few minutes later. So we put him on a non-rebreather, which helped to alleviate that problem. But also associated with this, during transport, he would have episodes where he would become even less responsive than he was initially, and it appeared that maybe his eye gaze was fixing to the right. And then we would stimulate him, and his eyes would go back to normal, and he would wake up a little bit, and his oxygen saturations would come up, and then he would become somnolent again, and his eyes would focus off to the right. I want you guys to consider that case for a minute, because I can tell you that just in that 3-second or 30-second discussion, there's at least 2 major errors that I made in the care of that patient. 2 major errors that have significant effects on that child's overall outcome, and mistakes that I don't want you to make, but mistakes that are easy to make, right? I like to think of myself as an expert in pediatric care, especially in pediatric critical care, and I made them without even noticing. So it's really important that we focus on those key priorities in the pre-hospital setting, and I'm going to come back to those. If you guys know what they are, terrific, but I'm going to come back to them here in a second. So, you guys get a similar call. What are going to be your pre-arrival priorities? We always focus on, in pediatrics, the pre-arrival priorities, right? Have an age-based dosing app so that you can get medications drawn up, at least ready in your brain for what dose you're going to need for that patient ahead of time, okay? The one problem with Brasselotape is Brasselotape requires a patient. You cannot get your doses and everything together without a patient in front of you and the tape next to that patient. age-based dosing apps have really allowed us to move the pre-arrival care, sort of maximize the pre-arrival care for these patients. And so what are going to be your priorities for this patient, for a traumatic brain injury? I think it's really important to consider now, kind of in your own head, what am I going to do for this patient? How am I going to prepare for this patient? Okay, and I'll tell you, I forgot to mention the age, but I think the kid was 4 or 5 years old, 4 years old at the time, so perfect age range for pediatric traumatic brain injury. But think about what your priorities would be, and we'll kind of discuss them as we go. If you don't use the right tools to look for the signs of traumatic brain injury, you won't see it. Okay? The problem with the management of traumatic brain injury, especially in the pediatric population, is that quote that I showed you guys at the beginning. So traumatic brain injury in children, it is a leading cause of death and disability. It is the #1 cause of life years lost across the board. Traumatic brain injury affects the old and the young, and actually disproportionately the young, so the amount of life years lost after that injury is more significant than any of these other disease cases. Okay? So traumatic brain injury is such a critical factor for children. It is the most likely pediatric injury to end in disability or death. 475,000 people in the U.S. age 0 to 14 will sustain a TBI annually. 90%, no problem, right? They got their quote-unquote bell rung in a football game. They did just fine. They rolled off the bed. They had a loss of consciousness for a moment and ultimately did fine. I can tell you, I diagnose concussions all the time in the emergency department, and parents ask, what's going to happen? How do we know, what the outcome will be? And my response is, we all in this room probably had a concussion at one point in our life, right? It's pretty common, and most of us end up doing fine. 37,000 are hospitalized for one reason or another, whether that's a skull fracture, a small intracranial bleed, or something more serious. And then 2,685, at least from this 2017 data, again, probably higher now, shows that those will ultimately die because of their injury. Death rate is higher in younger children, especially those younger than 4 years of age. So really, really important to keep that in mind. When I talk about pediatrics, and this goes for in general, if you are 12 or under, I think of you as a child, okay? 8 to 12, there's some variability. If you're a 65-kilo 9-year-old, then you are probably pretty close to an adult. If you are a pubertal mature 12-year-old, then you could be treated as an adult. Anybody 8 and under, so there's wiggle room there, right, between 8 and 12. 8 and under, you are a child, full stop. You cannot be treated as an adult. You cannot have adult rules apply to that patient. They are a unique population. 4 and under, they should really be treated as children because their anatomy and physiology is so unique, okay? And when you get younger than that into like the perinatal period, so a neonate, 30 days old, 20 days old, an ex-preemie baby, then it's like, there's no question. Nobody questions whether those should be treated as pediatric patients. But I really want to think about children as 8 and under, and especially 4 and under. Okay, and why is that? Well, anatomy changes with age. So on your left, you have an adult review of the chest and abdominal structures, and on the right, you have what is essentially an infant, so a newborn baby. You can see here, and I go into this at length in my trauma talk, but you can see there is significant differences in the anatomy, not the least of which is how high up the rib cage is on the pediatric patient. So everything is lower down in the abdomen, much more exposed to trauma, right? So a leading cause of death in children from blunt trauma is going to be liver lacerations, spleen lacerations, and that's because they're very exposed. So if you look at the left lobe of the liver on the child on the right, compared to the left lobe of the liver on the adult on the left, the liver is almost completely covered by the lower part of the rib cage in the adult, whereas in the child it is completely exposed and it also comes completely across the abdomen. So really significant differences there. There's just not enough real estate in the pediatric body to protect all of these organs. On top of that, they're skinnier, they have less subcutaneous fat, and so there's just not a lot of protection. Not only is there not a lot of outside protection, there's not a lot of inside protection either. Their fat that is around their organs is also significantly decreased. So they're much more likely to be injured. But when it comes to traumatic brain injury, that also holds true, okay? So what do we love about children? Again, 8 and under. We love them, well, we love them for many reasons, but one of the reasons we find them so cute is because it's a large head on a small body, right? So kids have extremely large heads, tiny little necks, tiny little bodies, okay? You can think of them like a lollipop almost. And what does that mean? That means that those children are going to be more likely to injure their head when they fall. The neck isn't strong enough to protect the head, and it's going to be, the head itself is going to be a much larger part of their body. We talked about less subcutaneous tissue, right? That's true for their head as well. And then the craniofacial ratio is at its greatest. What does that mean? That means they essentially have a 5 head, okay? Small midface, eyes, nose, mouth, everything is really close together, and they have a huge forehead, okay? That forehead creates a great opportunity to be struck by forces, okay? It's a huge surface area to contact things. The sinuses, now sinuses do begin to develop when you're born, and even in the prenatal period, but they don't fully mature until you're older. And so, gosh, what is it called? There's a theory, I think it's like the crush zone or something like that, that they use in pediatrics. And the idea behind that is older people have a lot of face and sinuses and bones that can break to help brace the impact before it hits the brain, okay? Children have very underdeveloped sinuses. All of their facial structures are right here in the middle of their face. And so what does that mean? That means forces are much more efficiently delivered from the outside of their body into their skull. On top of that, children have less myelin. If you think of your neurons as sort of these dashed lines connected to each other, when you're really little, there's no myelin on these, or very little myelin. And myelin is an insulating protein. And what it does is it allows for efficient transfer of a neuronal impulse from one of these neurons to another. Okay, so for those of you who have little kids or who are around little kids, especially when they're really little, they have a significant startle reflex. So if you were to suddenly jostle them or something, they'll kind of go like this, and their arms will continue to shake. And that is normal. That's because they lack the myelin on all of their neurons in order to control those impulses, okay? It kind of goes crazy on them, all right? When you get older, you develop this sheath that goes around your neurons, and it insulates them. And it does a couple things. One, it prevents those sort of exaggerated responses. It helps to control the neuronal impulses, but it allows neuronal impulses to move faster. Additionally, it stiffens up the neurons. So in your brain, in a child, it's very, very limited amount of myelin. Percentage of myelin is very low. The amount of water in the brain is very high. This gives a pediatric brain, again, especially under 8 years old and 4 years of age, almost like a jelly-like consistency, okay? Whereas you, listening to this, you have a lot of myelin, and you have less water, so your brain is stiff like a hard-boiled egg, okay? You could imagine if I shake a hard-boiled egg in my hand, not a whole lot is going to happen, right? Not unless I shake it really, really hard. Put a scoop of jelly in your hand and shake it up, right? It's a total mess, okay? It has very, very minimal ability to resist those shearing forces. And so the child's brain is much more at risk for shearing injury. Loss of gray-white matter differentiation, meaning that the neurons all shear away from each other and cause significant diffuse axonal injury, right? I'm sure you guys might have heard these terms. You might see this on your ESO reports from hospital outcomes. But this is pretty unique to the pediatric population, right? So if I were to shake you vigorously, you would be fine, right? If I take a 3-month-old or a 3-week-old or a 6-week-old and I shake them vigorously, they're going to end up with a trach and a G-tube and on a ventilator and living at Rankin Jordan, right? Very significant differences in the anatomy of a child that informs their reaction to a specific force. Think about shaking a 45-year-old and shaking a 5-day-old. Significant difference in outcome. We're going to come back to the neck and cervical spine. I think it's a hugely important topic. And we just had a patient the other day, actually, that had pretty significant cervical spine injury that I want to talk about as well. So I'll come back to that. All right, not only does the anatomy change with age, but the mechanism changes with age. If you're under 14, you're most likely to fall. Over 14, you start to do some really stupid stuff. Adolescents make bad decisions. They jump off things. They drive cars too fast. They ride their bikes too fast. They don't wear helmets, all sorts of things. If you further break it down outside of just falls, then you could say 48-year-olds have falls plus motor vehicle accidents, bicycle-related accidents. If you're under 4, again, those abusive head injuries become much more common. Motor vehicle accidents still common. And then if you're less than 2, you're really at high risk of abusive head trauma. And to hammer that home, for every 100,000 children under 1 year of age, 35 will be hospitalized with abusive head trauma. That is a shocking number, and to give it some context, that's the rate that we see neonatal meningitis or acute lymphoblastic leukemia in the pediatric population. So really, really high rates of that kind of stuff. And so it's a must-not-miss diagnosis for everyone watching this. When you think of traumatic brain injury, the next thought I want you to have is abusive head trauma. If you see a patient in a pre-hospital setting and they are a child and they are acting like they have a head injury, meaning they are an undifferentiated altered mental status patient, you're going to think about what 2 things, right? Opioid exposure and traumatic brain injury. And when you're thinking about traumatic brain injury, abusive head trauma jumps right to the top of your list of concerns. So boom, 2 seconds, you have narrowed down your diagnosis to 3 things that absolutely cannot be missed. Seems easy, but we miss it all the time. And if anyone is watching this and saying, I haven't seen any cases of abusive head trauma, I can promise you a case of abusive head trauma has seen you and you just missed it. It has happened to me. This is not picking on you, but I can tell you in the emergency department, I would be a fool to say I have caught every case of abusive head trauma. There's no way, right? It can be very subtle in its presentation, but we know that it is very common. So in order to not miss it or limit the number of misses, you have to consider this as a high likelihood diagnosis for your pediatric population. Because the presentation is so nonspecific and there will be absence of outward signs, okay? So I talk about this at length in my trauma talk, but in the box of things that we're never gonna say again, I want you to put no external signs of trauma, right? Low suspicion for trauma given no external signs, something along those lines, right? I want you guys to throw that away because children don't bruise, not in the acute setting. Okay, so if little Billy gets beat to hell by his dad and you arrive on scene 15 minutes later and you transport 10 minutes to the hospital, that's been 30 minutes since the injury. I can almost guarantee you that 4-year-old is not going to have external signs of trauma. If they do, great. All the more reason to know that there was injury, but it's a very good chance that they won't. And so you have to maintain a high suspicion of internal injury. And then this is something, we'll see in the emergency department, but subdural hemorrhages is really significantly common in abusive head trauma. Okay, so what are the now that I've sort of gone through this long list of why traumatic brain injury is terrible and how we need to keep a high suspicion for it, well, what are we supposed to do about it? Well, the priorities for pre-hospital traumatic brain injury are actually pretty straightforward. And this is where I'm going to kind of get back to the case that we were talking about, the one where I screwed everything up. But the priorities can be narrowed down, and this is directly from a neurosurgeon at St. Louis Children's Hospital, so pediatric neurosurgeon, is don't squish the brain and don't starve the brain. And the idea behind that is don't squish the brain, meaning don't let the brain swell and cause increased intracranial pressure. And don't starve the brain, meaning don't make it anoxic or lack of blood flow. Okay? So how are you going to do that? You're going to do that by preventing what we call secondary injury. So primary injury is the child's head hitting the windshield in the car. You're not there, you can't fix that. The bullet going through their head, none of that is going to be solved. Their head hitting the pavement from falling off a bicycle, that is primary injury. It's rapid, it's extremely devastating, and you can't do anything about it. What you can do something about is what we call secondary injury. So I punch you in the arm, right? That injury is there, it's not going to change. But then you start to develop a bruise. Your arm starts to get a little swollen and sore. So I say, okay, well, let's put ice on it, and let's take ibuprofen, and let's wrap it in an ACE wrap, and let's elevate it. All those things are preventing secondary injury to that bruise, to that site of impact on your arm. Same thing is true for a traumatic brain injury. Your goal is to prevent that brain swelling and that's starving the brain of oxygen and blood flow, oxygen and nutrients. This is the Monroe Kellie doctrine, and the idea behind it is that the skull is a fixed space, meaning that if you have skull, you have CSF, you have blood, and you have brain. And that's all that fits inside, right? So you have this fixed closed space with these things in it. If the volume of one increases, the other volumes must decrease, right? Because it's a fixed space. Additionally, as one volume increases, your body does a pretty good job of auto-regulating, and we'll talk about Cushing's triad here in a second of how your body auto-regulates. But your body does a pretty good job of auto-regulating until a point. And then there is a rapid increase in intracranial pressure, and that's when herniation occurs. So our job is to intervene in these first few phases of this rapidly increasing intracranial volume and increasing intracranial pressure to prevent that sudden rise, okay? So if you think about increased intracranial pressure, the symptoms, unfortunately, right, traumatic brain injury symptoms are nonspecific. Signs of increasing ICP, again, nonspecific. Another reason we have to maintain a high index of suspicion. But headache, vomiting, irritability, lethargy, visual disturbances, gait abnormalities, weakness, depressed level of consciousness, abnormal vital signs. Cushing's triad, so Cushing's triad is bradycardia, hypertension, and then respiratory irregularity. And the reason that occurs is because your brainstem, right there at the base of your skull, is the primary site of respiration, okay? As you start to squeeze and increase the pressure on the skull, so as you start to go from phase 1 to phase 2 to phase 3, you are increasing the pressure inside that fixed space. And remember, your body is going to try and not starve the brain and not squish the brain. So it's going to make its own physiologic changes in order to prevent those things from happening. The first thing it's going to do in order to not starve the brain is it's going to jack up the blood pressure. So your systolic blood pressure rises rapidly as your brain tries, or your body, tries to compete with the rising intracranial pressure. Intracranial pressure goes up, systolic blood pressure must go up in order to maintain perfusion to the skull, okay? So that's how you don't starve the brain. Unfortunately, to not squish the brain, you can get rid of CSF in the short term, so your body will get rid of some of the CSF by putting it down into the spinal cord or trying to reabsorb it, which is a slow process, but that is very limited, and then ultimately herniation is what occurs when you are no longer able to accommodate that. But then also, as that pressure goes up, as that brain begins to get squeezed inside the skull, it moves down through the foramen magnum, which is this large space at the base of your skull where your spinal cord descends into your axial spinal column. As that starts to get squeezed down, the respiratory center, remember that central part of your brain that does respiration, also starts to get squeezed. And as it gets squeezed, your respirations become irregular, okay? That also affects your heart rate because your vagal nerves, which stimulate your heart rate, are actually also passing through that area of your skull. They get squeezed as well, and you get bradycardia. Hypertension, bradycardia, irregular respirations. A sign to you that that patient is in danger of imminent herniation, okay? Great if they're there. They're rarely there together, and even if you see some of them, I can tell you from personal experience, it doesn't mean the patient is herniating. I have called neurosurgeons to the bedside and said, look, they're hypertensive, they're bradycardic, and their respirations are irregular, and the neurosurgeon has said to me, I don't care, not herniation, right? So, and I've had patients who are herniating who don't have those symptoms, who don't have that triad. So it's great if it's there, but it doesn't really tell you. It's not super sensitive or specific for that finding. So don't wait until you see Cushing's triad in order to treat a patient for increased intracranial pressure. I want you to think about these other things. Okay, so what are the priorities? This term was put together by a trauma surgeon and EMS physician named Dan Spaite, who comes out of Arizona, I believe. And he decided on the term H-bombs because it was something that could be remembered in the ditch in the middle of the night when it's raining, and everybody could say, okay, we got to avoid the H-bombs. And the H-bombs are hypoxia, hypotension, and if you're ventilating the patient, hyperventilation. So you avoid hypoxia, hypotension, and hyperventilation. Remember, don't squish the brain, don't starve the brain. Hypoxia, hypotension, squishing and starving the brain, right? So really, really important to keep those in mind. Why, if I hyperventilate a patient, am I going to decrease their cerebral perfusion? I think intuitively we might say, well, if you hyperventilate them, you increase their intrathoracic pressure, and then blood doesn't flow down from the brain, and then so no blood flows up, and so you get sort of a backup. That's a true statement, but the primary reason is that when you hyperventilate somebody, you rapidly drop their blood carbon dioxide levels. When your brain receptors see lower and lower carbon dioxide levels as they pass by, your brain will constrict your blood vessels. It's a sign to the brain that I'm getting too much blood flow, I'm getting too much nutrients, and so it will constrict your blood vessels. When you constrict blood vessels leading to the brain, you decrease perfusion to the brain. So you're sort of attempting to treat that patient who has increased ICP, but you're ultimately harming the patient. If you hyperventilate them for more than a few minutes, you're actually going to cause more harm than good. You're going to start starving the brain of nutrients. So hyperventilation is also just as bad as hypotension and hypoxia, and I'll come back to that here in a second. What Dr. Spaite did was he took the traumatic brain injury guidelines, national guidelines that are sort of ubiquitous and nobody uses, but they exist, and he read through the whole guidelines, all, however many pages it was. And he said, I kept reading these guidelines and all it told me was prevent hypoxia, prevent hypotension, and don't hyperventilate patients. And then it never talked once about preventing those things. It just said treat them if they're present. And he said, well, why don't we just prevent them, and then we never have that problem in the first place? And so what he did was the Excellent in Pre-Hospital Emergency Injury Care, or EPIC study. There's an EPIC study and an EPIC for Kids study, which is just a sub-analysis of the EPIC study. And he said, okay, if we just prevent these things, if we say you've got a patient with a loss of consciousness and 911 is called, your job is to place that patient on a non-rebreather at 15 liters, prevent oxygen desaturations less than 90, give them a fluid bolus to prevent any hypotension less than 90, and then if you ventilate them, maintain a end-tidal CO2 of 35 to 45. If you do those three things, you will significantly impact the outcome for those patients. And it was more significant in the patients who had severe TBI. So let me explain. There's a critical group of traumatic brain injury, the ones who have a bullet pass through their brain. Probably not going to make a huge difference when you put them on a non-rebreather or give them a fluid bolus, right? The injury is so significant and so severe that there's nothing we can do to fix that, okay? And then there's a population where it's like little Billy rolled off a 2-foot changing table and he had a 10-second loss of consciousness and then he was fine. None of the interventions we're going to do are going to make an impact because he's going to be fine regardless, right? But there's that sweet spot of patients in the middle who have severe traumatic brain injuries, not the critical ones, not the mild ones, but the more severe ones. Those are the ones they saw a significant impact on. And you can see in the severe TBI group, the adjusted odds ratio was 2 for the adult population, and I'll show you the pediatric population. And in the intubated severe TBI, it was actually closer to 5, or 3.14, excuse me. So pretty significant changes. So, 2 and 3 more times likely to survive your traumatic brain injury. If you go on to the pediatric population, they did the same things. Don't have hypotension, don't have hypoxia, and don't hyperventilate the patient. And also, I want to clarify too, what he said was, if their respirations are irregular at all and you're concerned in any way, just BVM ventilation. Skip the non-rebreather, go straight to BVM ventilation. And I think in the setting of traumatic brain injury, that is such an important part. We never want to, there's always this hurdle to get over to put the BVM on the patient and start ventilating them, and he lowered that. He said, if you're concerned at all, you just put them on a BVM. Okay, and I'm going to come back to another study here that's going to talk about the value of a BVM as well. But you can see in the pediatric patients, Again, the severe group, right, those ones that are most likely to benefit from this, 8 was the odds ratio for survival at hospital discharge. 8 times more likely, right? Significant, significant difference. And so, these are crazy odds ratios for just doing the things that we already know we should be doing. He didn't go around and say, we're going to do this new novel thing. He said, here are the pre-hospital guidelines for traumatic brain injury that we all know. I just want you to do the 3 things that this guideline says. Okay? So, I give him a slide because he did such important work, and he graduated from Washington University in St. Louis, so I can't help but give the guy a slide, although he never responds to my emails, so, it's just the way it goes. But anyway, has done significant work. But what he did, I didn't mention it, was that he trained 6,000 or 600 people as train the trainers, right? So 600 people went around to 11,000 paramedics in the Arizona area, and all they did was they put them through a 1-hour lecture and then a 1-hour hands-on skill station. And that's it, right? So the next time you guys or you're sitting through this talk, or the next time you're sitting through a talk in person, and you're thinking, this is a waste of my time, I will tell you that this man would argue with you because there's an 8-fold increase in survival in pediatric traumatic brain injury just from going around and giving 2 hours of lecture to paramedics in the Arizona area. So really, really important work to show you the value of even just this basic level of education is so critical. Remember how I talked about hypoxia and hypotension as 2 critical factors in the H-bomb? So what he realized is that if you look at the depth and duration of hypoxia, of hypotension, the same is true for hypoxia. But if you're hypotensive to 85, that is less severe than being hypotensive to 75, okay? And your chance of survival goes down with each lower and lower blood pressure, each lower and lower systolic blood pressure. So and it's almost a linear relationship. So if my blood pressure is 88, I have a much better chance of a good outcome than the patient who's 78. He found the same thing with hypoxia. If you're 90, that's the bottom limit of normal that we tolerate. If you're 88, that's worse. If you're 85, that's worse than 88. If you're 80, that's worse than 85. And again, with that linear relationship. And then he said, well, what if I look at the combined effect of hypotension and hypoxia and mortality for traumatic brain injury? And he found that they're worse. If you put them together, hypoxia and hypotension, you have a significantly higher chance of mortality from those 2 events. Even just one episode. We won't know the effects of the pre-hospital care until long down the road for the patient. This is the slide that's going to tell you that actually what you do matters, okay? If you have hypotension, remember that patient I told you about who had the hypoxia 2 or 3 times down into the 80s? And I blocked it out of my brain, but I'm pretty sure he had hypotension as well. I significantly increased the chance of mortality for that child just from not acting on those things or not preventing those things, okay? Now, if you had put that child in the back of the ambulance and I get in the back of the ambulance with you and I say, hey, I want that kid on a non-rebreather, I want you to put in an IV and give him a liter fluids or 20 per kilo or whatever it might be, and if we have to ventilate him, don't go below an end tidal of 40. You'd be like, dude, take it easy, right? I mean, look, he's just sitting on the stretcher, he's fine, he's breathing on his own, we don't need to do anything crazy like that. That would be a reasonable response. Hopefully some of you are saying, I would never say that, I would have already done those things, and you're a fool. But some of you might be like, yeah, I probably wouldn't have done anything. These studies are to empower you to do something. Don't let the patient be hypoxic. Don't let the patient be hypotensive. Treat those things aggressively, prevent them from occurring, okay? Because we know that those have significant morbidity and mortality down the road long after we in the pre-hospital setting are gone. Okay, now what inevitably comes up when you talk about pre-hospital treatment of traumatic brain injury, and I will tell you that I could stop the talk right now and you have all the information you need to go out and care for the next traumatic brain injury, adult or pediatric. You're going to put them on 15 liters non-rebreather. You're going to give them a fluid bolus. They did a sub-analysis of the EPIC trial, and they found that actually higher and higher blood pressures were better, 130, 140, right? Much better than 110. Because if and I'm getting off on a tangent, but I think it's important. If I take you outside and run you over with my car, and then I take you to the side of the road and I check your blood pressure, I would hope it's not 110, right? If it's 110, that is concerning, right? No one would say that that's fine. You were just run over with a car. Your blood pressure should be through the roof. You have a stress response to that event. Why then would we assume after I cause significant trauma to your brain, would a low blood pressure be acceptable? 110 is no longer normal. If you're in the clinic seeing your primary care provider and he wants to know how you've been doing, he checks your blood pressure and it's 110, you're like, fantastic, I'm doing great. If you're on the side of the road after a motor vehicle accident at 2 o'clock in the morning and your blood pressure is 110, even though those numbers are the same, one is significantly more ominous than the other. And so, Dan Spaite looked at that and he said, well, we probably should have even higher blood pressure. The body is physiologically trying to not starve itself and not swoosh itself, and it's increasing its blood pressure in response to increasing intracranial pressure. So why would we iatrogenically make it lower? So I would argue you even need a higher blood pressure than that. Traumatic brain injury and intubation. This is a topic that both Dan Spaite and Dan Davis, ironically they're both named Dan, and ironically they both are on the West Coast, and ironically they're both EMS physicians, but they have been thinking about this for a long time, years and years and years. And it's a topic of discussion that has evolved. And I think when you guys all hear about pediatric intubation, you'll immediately think, oh, everybody tells us not to intubate children, right? And in a lot of ways, that's true. Now, the landscape is changing. We have more video-guided intubation, and so I think our first-pass success rate is rising in the pre-hospital setting. But overall, that is kind of the recommendation. You don't need to intubate children. They do just as well with BVM ventilation and an airway adjunct, or a supraglottic airway, which has gained popularity in the last few years. And so, what about in traumatic brain injury? You just said, don't let them be hypoxic. Well, the one way I'm going to make sure they're not hypoxic is by putting in a breathing tube, a definitive airway, and delivering oxygen directly to their lungs, right? That seems to make sense. What these experts who have looked at this for the last 10 or 15 years would say is that it may not be bad necessarily, but it's definitely bad if you're bad at it. If you're not skilled at intubation, then you should not be intubating patients with traumatic brain injury. And the reason is because remember I said, and I'm going to focus on this for the next few minutes, hypoxia is a significant harbinger of increased morbidity and mortality. One episode of hypoxia less than 90 increases morbidity and mortality. Well, Dan Davis looked at this, and they took 87 patients, and they looked at desaturations around intubation. And they found that if you get to 93%, there is a precipitous drop in your theoretical risk of desaturation. Meaning that when they lined up these 87 patients, once those patients hit an oxygen saturation of 93 or less, if someone went to intubate them, there was a very, very good chance, almost guaranteed, that those patients would drop their sats below 90 at least once. Okay? So you might say, well, I'm not going to intubate people who are 93%. Well, you're not an anesthesiologist. You're not working in an operating room where everybody's just getting, tonsillectomies and adenoidectomies and appendectomies all day, and these are otherwise totally healthy patients. You're in a ditch in the side of the road at 3 o'clock in the morning when it's raining, dragging somebody out and then trying to intubate them in the back of the ambulance. I would argue most of your patients in traumatic brain injury are not going to have an oxygen saturation above 93%. So he's saying, look, if you're going to try and intubate somebody, you better be damn sure that their oxygen saturation is above 93% because you're almost certainly going to make them hypoxic. And remember, hypoxia is the one thing you're trying to avoid. So by attempting to secure the airway, we could potentially be making that patient's situation that much worse. Okay? So really, really important to keep that in mind. There he is, if you want to know anything about him. He also doesn't respond to my emails, but that's neither here nor there. And so his sort of, that first slide was really the biggest, most important part of this. But to give you his progression on this, in 2003, he said RSI for intubation increases mortality in the setting of traumatic brain injury. In 2004, he said hyperventilation and severe hypoxia are associated with increased mortality. Both things occur around intubation. And then in 2011, he said, the relationship between out-of-hospital airway management and outcome in trauma patients with a GCS less than 8 might be better if you are skilled at intubation. But if you're not, don't do it. And then in 2022, he said, okay, you can do it if you're good at it because it could potentially help, but if you're not good at it, you shouldn't be doing it, right? So you can see his progression from it's bad, to maybe it's okay, to it's probably okay, but you better be great at the skill because otherwise you don't want to end up on this bottom end of the curve, right? And you can see the time here down along the bottom, which I forgot to mention, 1 minute, 2 minutes, 3 minutes. So right about 4 minutes is the time that patients start to have a precipitous drop. And I would love to do this study, although I probably won't ever get around to it. But I would love to be in the emergency department in the trauma bay and after every intubation walk up to the person who intubated and say, how long did that take you? And see what they say compared to what the actual time was. Because, in the pre-hospital setting, I bet it's just as bad. I bet you that we think we intubate a lot faster than we do. And I would argue that there are definitely times that we get to 2 and 3 minutes, especially in a difficult airway, facial trauma, aspiration, blood, vomiting, much more difficult to get that airway, much more likely that we're going to get further and further down the road. So management goals, this has been beaten into your head, right? Everybody knows. So the goal is to optimize your cerebral perfusion pressure. Again, that is ICP, systolic blood pressure, making sure that your systolic blood pressure can meet and exceed your intracranial pressure. That's your cerebral perfusion pressure. So if your cerebral perfusion, if your intracranial pressure is 30, random number, and your systolic blood pressure is 50, then your cerebral perfusion pressure is 20, okay? So really important to keep that concept in mind. You have to raise your systolic blood pressure to meet the rising intracranial pressure to maintain perfusion, and that's why super high blood pressures in traumatic brain injury are extremely ominous, because that tells us very high increased intracranial pressure. So the goal is to optimize the perfusion pressure. Bag valve mask, airway adjuncts, or intubation, and again, intubation, I'm going to come back to it because I think it's a mixed bag. If you're skilled, if you have, if you're a high-functioning agency, which you guys are, but if you're a high-functioning agency and you have the skills and you have airway backups and you've got expert clinicians who have done this before, then sure, I think it could be beneficial. But you got to get it quick and you got to get it without hypoxia, and avoiding secondary brain injury, the H-bombs, hypotension, hypoxia. Not hyperthermia, that's a typo. It is hyperventilation, although hyperthermia is also bad, but it's not one of the H-bombs. Always, always, always resuscitate before you intubate. So when we go back to this slide, what I didn't tell you was that when they went back and looked at second attempts, so of all these attempts at intubation, the patients who required a second attempt were bag valve mask ventilated between attempts. And for the ones who were less than 93 when they intubated the first time, when they bag valve mask ventilated them in between the first and second attempt, they got their saturation up above 93. So up above the initial oxygen saturation before intubation. My interpretation of that is we should be resuscitating, bag valve mask ventilating these patients to maximize their oxygen saturation before we intubate them. And some of you watching this may say, well, I'm going to put their bellies, it's going to fill up with air, right? And then they're going to vomit, and then they're going to aspirate, and then I'm going to be in a really big trouble, right? Well, I would argue that aspiration of a small volume of vomit and the resultant pneumonitis that occurs from that is pretty trivial compared to the direct correlation with morbidity and mortality that hypoxia carries. So I would say you should bag them. If you maintain a peak pressure less than 20, you're going to have very limited opening of the esophageal, the upper esophageal sphincter, or getting air into the esophagus. You're going to have very little opening of that, and so you're going to have very little insufflation. And so the risks of that are pretty well mitigated as long as you're not giving super high pressures. So ultimately, I would say ventilate them first. And Dan Davis even goes a little further, and he's done some studies that have looked at vasopressors. One of the 10 commandments in trauma is don't give vasopressors to a traumatic injury, right? And he has actually turned that on its head and said, well, in traumatic brain injury, giving them vasopressors, bag valve mess, ventilating them before you intubate has a better outcome for those patients, and less of a chance of hypoxia than not doing those things. So always, always resuscitate before you intubate. And if you're about ready to tube a traumatic brain injury with an oxygen saturation of 92%, I hope you and your partner are looking at each other and saying, we should hold off until we can get this patient's oxygen saturation up. What about in children? So that data I just showed you, that precipitous drop at 93%, that was adults. And if you look back, if I can do this, it's at, what is that, about 300 seconds? So almost 6 minutes, ultimately, when people fall off the cliff. Well, children, I can tell you for sure, and when I was putting this talk together, I was like, well, children are never going to make it that long. But how long can children actually go before they become hypoxic? Luckily, in Cincinnati, they did a study on this, and they looked at factors associated with desaturation during rapid sequence intubation in pediatrics. And what they found, and you can see, so this is all in hospital, so not paramedics or EMS professionals, but this is all pediatric, emergency department, ICU, and anesthesia, and they're, obviously have them separated out. But you can see that the average attempt was somewhere around 30 seconds, 30, 35 seconds. That was the sort of mean. And then, you have your outliers at greater than 90 seconds. But what they found was that as you got increasing, and I think I put it in the slide, next slide, as you increased the duration of attempts, not the number of attempts, but the duration of attempts, you had almost a linear association with the increased risk of hypoxia. And the really sort of sweet spot was about 45 seconds. So you needed to get the patient intubated in under 45 seconds. Now, I grant you, this is trainees, but it's a significant portion of these are outside of that window. And these are people who you would argue, I mean, Cincinnati is a major children's hospital. They see at least as much trauma as St. Louis Children's Hospital. They see at least as many sick children as St. Louis Children's Hospital. And so my assumption is that they get a lot of reps at the airway. And they have a pretty skilled faculty to get airway interventions. So if you're watching this as a relatively new medic or a medic who's never intubated a child, I would hope you're not thinking you're going to get it in the 0 to 15 second window in the back of an ambulance or on the side of the road. Realistically, most of us are going to fall into this 45 to 60 second window or more. So the likelihood that we're going to have a hypoxic episode starts to rise really quickly. So now you're saying, and I want to be clear, this was most evident in children 2 years of age and under, 24 months and under. And this was not a trauma group of patients. This was medical arrest, respiratory arrest, those types of things. So its generalizability is somewhat challenging, but I would argue that it would be pretty hard to believe that if a 2-year-old starts to desaturate after 50 seconds in the setting of medical cause of respiratory failure, they're probably going to desaturate around that point when it's a non-medical or traumatic cause of respiratory failure. So, really, really important to keep this in mind. And if you're thinking about intubating a child in the setting of traumatic brain injury, then you really got to be even better than the adult population, because you only have 45 seconds, whereas the adults, I mean, it was up to 5 minutes you could go before they had significant desaturations. I'm going to briefly go through cervical spine injuries. This is another really important topic. Luckily, it's very uncommon. It's often due to high-speed accidents, motor vehicle accidents, ATV accidents, those sorts of things. It can be associated with birth trauma, vacuum or forceps extraction, and there are structural considerations. If you're ever intubating and you have a patient with concern for cervical spine injury, which should be all your trauma patients that you're intubating, then be good at this skill, the skill of inline manual stabilization, right? Be comfortable doing this, be good at it, because this is a really important skill that you're going to need in the moment. It requires 2 people, hint, hint, so can't do it by yourself. So briefly, remember it's a large head on a weak neck. Younger patients, the fulcrum is higher up, meaning that rotational point is much higher up in the cervical spine. So right around C1, C2. This is C2. C1 rotates around C2 like this, okay? So, and this is a foramen. This is a space that has ligaments attached to it. And this is your cervical spine runs right back here, okay? So this is that axis, right? The dens is what it's called. It's an axis upon which the cervical spine rotates. So if you guys think about trisomy 21 patients, they have laxity in that area, so they are much more likely to have cervical spine injury with significant manipulation. So it's atlantoaxial mobility. And you can have, in younger patients, because this is C1, this is C2, and then the base of the skull is right here, okay? And so it opens right into the base of the skull, and this is your occiput, which I won't draw, but this is your occiput here. So you can have occipital dislocation, and you can have atlantoaxial dislocation. So whether it's C0 is what people will call this. If it's rotation along this point, or if it's rotation along this point, you can have significant traumatic brain injury and significant harm to the patient. Younger patients, much younger patients, are going to have more significant injury in the higher cervical spine. Adolescents, much lower down. So you guys get in a car accident, C6, C7 is most likely to be injured if you're going to injure your cervical spine. A 6-month-old gets injured in a car accident, it's going to be right at that junction between the base of the occiput and C1, and then the little bit older kids, 4, 5, 6, 7-year-olds, that's going to be C1, C2, okay? So that rotational point is much higher up than in the pediatric patient. So what is that? Oh, and also, excuse me, I forgot to mention, the ligaments that hold everything together in your cervical spine are much more relaxed, okay? So it allows for significant movement, okay? So you might have a patient who is in a car accident and has movement of their cervical spine, C1 on C2, because of the laxity in the ligaments, that then goes back to normal. By the time I get an x-ray of that, but all of the cervical spine line up perfectly. I never saw that there was actually injury there. So you can have injury without clinical signs. That's why these patients oftentimes will remain in a cervical collar if there's high suspicion for injury until they get an MRI where we can actually look at the spinal column itself. So just really important to keep that in mind. I'm going to just briefly cover this just for the sake of time, but this is Waddell's triad. This shows you that mechanism informs injury. I can cover this when I talk about just trauma in general. But basically the idea behind it is you get, if you have a child crossing a road who gets hit by a car, you can have several injuries that are informed just by the mechanism. So femur fracture on the left side, you get chest contusion on the front of the chest, the child is thrown, you get a traumatic brain injury with head injury on the opposite side, and then you can have high cervical spine injury from that contact with the ground. Because the child's head is so large, you have cervical spine injury and head injury because the head is the first thing to hit. So just by, we're going to a pediatric motor vehicle accident, just like that kid I had, all of these injuries are possible, along with your more typical injuries that you would expect, like a liver laceration, small bowel injury, spleen injury, those kinds of things. So mechanism is really critical when you're thinking about what types of injury. This is spinal cord injury without radiographic abnormality. That's what I was talking about with that shifting of the cervical spine. It may have so much laxity that it moves, causes injury to the cervical spine, and then moves back, and by the time we x-ray it, it looks fine. These patients need an MRI. Anybody who doesn't know the difference between neurogenic shock and spinal shock, this is a critical factor to consider, okay? When you have cervical spine injury, you can have injury to the spine, to the spinal column itself that causes significant vasodilation. So you get hypotension, but you don't have the ability for reflexive tachycardia. That function in the nervous system has been knocked out. So you'll get a patient, you get them in the back of the ambulance, and their blood pressure is 80s over 40s, and their heart rate is 60. If you ever see something like that, where the patient's blood pressure and heart rate are not matching each other, then I want you, in the setting of trauma, I want you guys to think about neurogenic shock. It is different from spinal shock, okay? Spinal shock is where you have injury that causes pain and flaccid paralysis that gets better over time. Neurogenic shock can kill you. Spinal shock is rarely deadly, but it most commonly gets better with just steroids and time, but neurogenic shock can kill you. So the treatment for neurogenic shock is vasopressors. The same kind of vasopressors you guys would use to treat anaphylaxis, which is another vasodilatory shock. So you would treat them with like, phenylephrine or something like that. Epinephrine in the short term is just fine. But you have to keep a high index of suspicion for that type of injury. If you see a patient who's bradycardic and hypotensive, or even normal heart rate and hypotensive, always think about neurogenic shock. All right, so where do we go from here? Where is the future of the management of pre-hospital traumatic brain injury and cervical spine injury? Well, in the setting of the pediatric world, there has been a lot of good research recently to look at this kind of stuff. This is Dr. Julie Leonard again. She's out of Nationwide, but has done a lot of work with both St. Louis Children's Hospital and also with colleagues from Cincinnati who are on some of the previous studies I showed you guys. But she found that there's actually a really easy way to determine whether the pediatric patient has cervical spine injury that can help us walk back some of the imaging and immobilization that we do right now reflexively. And she just, I say awaiting results of a validation study, but she actually just published her validation study that showed that these factors are 98% sensitive in the identification of a patient, a pediatric patient with cervical spine injury. So I'll leave those up there. You guys can take a look at them just for the sake of time. I'm not going to go through them, but they're very similar to the adult world. If you guys are looking for resources and tools to help you manage pediatric trauma, obviously this talk is a good start, but there's more tools out there. So the Pediatric Education and Advocacy Kits, or PEAKs, they are put together by the Emergency Innovation and Improvement Center, which is part of the EMSC, Emergency Medical Services for Children. So it's a lot of acronyms, kind of a mouthful. But they have a lot of tools that you guys can access. Right now they have 6 PEAKs that you can get access to. You can see the most recent one is multi-system trauma. There's a lot of great tools on there, including tools for traumatic brain injury resuscitation algorithm. So if you guys are, want to get more resources, want to learn a little bit more about how to manage children in the pre-hospital setting, you can check any of these things out. There's also Pediatric Trauma SimBox or Telesim, where you can go through a scripted and designed scenario for pediatric trauma management. So a lot of great tools. And then there's also some podcasts on there, one of which is my podcast, the EMS podcast, Pediatric EMS podcast that you guys can check out. That's a great opportunity to listen to and get a little more insight as well. We do cover traumatic brain injury and cervical spine injury as well as general trauma. All right, so take-home points. In the management of traumatic brain injury, I would argue that all of the hard work, all of the potential benefit to those patients happens before they ever get to the emergency department. Neurons that go a minute, 2 minutes, 3 minutes without oxygen die and don't come back. It doesn't matter what magician the neurosurgeon is or the ER doc is. You as the pre-hospital professional, as the EMS professional, have the opportunity and I would argue the responsibility to intervene appropriately and rapidly and diligently in the care of children with traumatic brain injury in the pre-hospital setting to clearly redirect in a positive way the course of that patient's outcome. If you can maintain normal oxygen saturations, if you can aggressively treat seizure activity when you see it, which is something I didn't talk about, but that eye gaze deviation in the patient I had, pretty sure that was seizure activity that I missed, increases blood demand and oxygen demand in the brain. So rapidly treating seizures is also critically important. Avoiding hypotension and aggressively managing signs of increased intracranial pressure. Intubating only when you have the necessary tools, skills, and you've appropriately resuscitated that patient. If you can do those things well, then you can really make a difference for the pediatric population and you can mitigate significantly the potential outcomes, bad outcomes for these patients. So really, really important. Don't forget the H-bombs. And please check out the EIIC tools that are available to you guys to improve the pre-hospital care of children.